Hello, thank you for inviting me to talk on this topic. My name is Ian Greener. I'm a professor at Durham University in the UK. I'm going to talk for the next 15 minutes on decentralization without choice and competition, how to make health systems work better without markets. And I've also supplied a presentation which I hope will be helpful in supporting what I have to say. In terms of an outline, first I'm going to talk about how choice and competition are meant to work. This is at a theoretical level, so we can gain some sort of base, some sort of understanding of how this is supposed to make things better. I'm then going to work through problems with choice and then problems with competition, both theoretical and empirical. I'm then going to talk about some different ideas about how we can get healthcare organisations to work better without markets, or perhaps despite them, in terms of thinking about how we reward people and how we can try and make things work better within healthcare systems without the need to have excessive amounts of competition and choice in place. First of all, let's start at the beginning. So how are choice and competition meant to work? If we think about this in terms of the standard economic theory of markets, then we've got informed consumers making choices about where to go, where to spend their money. We've got resources attached to their choices so that they go to the providers that they choose. That's really important because that provides the reward for those providers then being good. That means in turn that the best providers thrive as they get chosen, and poor providers fail financially as they are not chosen. So that means we've got a strong incentive to provide good service for providers, which drives up the quality of the services that are on offer. This is the basic model of economics. This applies in virtually any good or service that's supposed to be out there. I think my contention is this doesn't work either theoretically or empirically in the area of healthcare. To work through this, let's deal with the problems about choice first of all. The basic observation here is if consumers don't make the right choices, then we have a big problem in using market mechanisms. We might as well allocate the money randomly. In healthcare, we have what economists call asymmetric information. That's information which isn't balanced on both sides in terms of supply and demand. Those receiving care find it very difficult to judge how good it actually is. Unless you're medically qualified, it's very difficult for you to judge the standard of a service that you're receiving. We can judge it on other things, which I'll come to in a moment, but intrinsically, if I get better, I would think that I'm getting a good healthcare service, but that doesn't necessarily stand up. I could be getting the very best one in the world and still not get better. Or as George Bernard Shaw, the British author, was very fond of saying, that the medical profession exists primarily to take credit for things that nature would have done anyway. I might just have got better, and I might associate that with the hospital or the service provider that puts that in place when it may have actually had nothing to do with them. What we therefore do as people is we judge other aspects of the service that we receive. If I can't judge intrinsically how good the care I've received is, then what I try and do is I judge things that I can judge. Like in the UK, we've had big problems about car parking, for example. So I might judge a hospital by how easy it is to park there. That seems to me to be a bit of a problem because that's got nothing to do with care quality. Equally, I might judge it by how nice the people are to me while I'm there. Now, that's important in terms of care, but again, it's not the most important thing. And it leads to some perverse outcomes, which I'll talk about in a moment. There's also evidence from psychology that we don't actually judge experiences or remember experiences more clearly very well. So if you ask me to judge how good the service I've received is after the event, then that can have real problems for me because what I tend to remember are the very good things and the very bad things, forgetting everything that was in between. And if I have one very bad thing, particularly at the end, that will tend to mean that I underestimate, that I regard the whole experience as being substantially worse than it was. There's lots of interesting research in clinical areas of this, that if you give a patient a little bit of pain at the end, which they will tend to regard the whole experience as having been bad, regardless of how good it was up to that point, because that's the thing they remember most about it. So we may not be very good judges of things even when we've experienced them. So, if we were actually being asked to make a choice as a consumer, as a patient in a healthcare marketplace, what would you choose? Well, we can measure waiting time. So we might choose the hospital with the shortest waiting time. But that might also lead you to what psychologists again call cognitive dissonance. So what's the problem here? Why have they got such a short waiting time? Is it because nobody else is choosing them? Are they no good? Well, fine, let's choose the one with the long waiting time. Well, that might just mean that they're not very efficient, or it might mean that they are very, very popular, so that might be good. But remember, we've got lots of other uninformed people making these choices. And do you really want to wait every time you make a decision about your healthcare? So let's pick the one, say, with the lowest mortality figures. But again, I think that leads to perverse outcomes. It can particularly lead to problems with providers trying to pick the most healthy people to treat, which is obviously not what we really want them to do. Or it can lead to them performing procedures on healthy people which aren't particularly necessary and avoiding the really sick. Again, we don't really want them doing that. These all lead to substantial issues. So I think my first claim would be, in terms of choice, there is no real basis for making any kind of informed choice as a health consumer in a health marketplace. And this isn't just a lack of information, it's a lack of ability for me to understand this information as an average kind of patient. Coming off the street, being told that I need to be referred for surgery, I don't know how I'm supposed to actually make the choice of where it is I go. In terms of competition then, if patients don't make the right choices, then there's very little incentive for providers to actually improve their services, particularly to improve the care that they're providing. There may, on the other hand, be really perverse incentives for them to try and improve the things that patients can actually measure, like car parking. So we might build a bigger car park. We might hire the most attractive staff we possibly can and get them to smile a lot. There's some really interesting research around nursing in relation to this, about nurses going home with their faces aching at the end of a long day because they've had to smile continuously. And they've kind of forgotten that they're supposed to be there to provide care. We might also say, as I've said earlier, that hospitals might try and restrict the care to only very minor cases or to providing care to only very healthy people because that won't affect the mortality figures. The only way this can possibly work is through what economists call contestability, which is by healthcare providers believing that patients are actually making much better decisions than they really are making. But even then there's a danger that they might end up losing out to the hospital down the road that's built the biggest car park anyway, because even if they're interested in providing better care, it's possible that patients won't really understand that. What they'll do instead, again, is make choices based upon how attractive the place is or who has got the biggest car park. And again, that's not really what we want our healthcare to be based around. So if we've decided that markets don't really work tremendously well because there are problems on both the supply and the demand side here, what can we do instead? Well, we can try and motivate or incentivize staff to try and improve or make things better for themselves. The obvious way to do this is to divide incentives up into extrinsic incentives, that's things that come to us from the outside, intrinsic incentives, things that might try and motivate us from the inside based upon our own personal goals. An obvious example of an extrinsic incentive is to pay people more. Now, the problem with this is that overwhelmingly the research evidence suggests that paying people more doesn't actually mean they provide a better service. This goes back decades, this research, and it's baffling to me why we still continue to have ideas like performance-related pay. How long does a pay rise actually make you happy for? Well, maybe a couple of days, and then what are we going to do the rest of the time? Equally, there are often real perversities around this, and the financial services industry provides one. So I provide a bonus for people who do really well. Well, what that leads to doing is people chasing targets rather than remembering what it is they're actually there for, which is providing care. So I don't think there's any evidence at all that actually paying people more or paying people bonuses actually motivates them to do a better service in healthcare. Intrinsic motivation, on the other hand, does seem to have evidence to support it. It's much better on this view of the world to appeal to people's professionalism, to say to them, look, okay, what we want to do is to try and improve services. What do you think? What do your professional ethics say? What do your own understandings around professionalism suggest we ought to do to improve? In other words, we build up better healthcare systems not from the top by dictating to people how we do things, but from the bottom by asking them first how they could make things better, by appealing to their professionalism, by allowing them to do a better job. Remember, we're talking about a caring profession here. We're talking about doctors, nurses, lab technicians, a variety of other people who presumably decided to enter healthcare because they wanted to make the world better in some kind of a way. Well, let's ask them, shall we? We've spent an awful lot of money training them. Now, wouldn't it be good to actually get their view on how we can make things better, rather than again assuming that we know the answer from the start, or politicians know the answer, or a bunch of people who don't actually have to provide the care know better than the healthcare professionals? By all means, we can measure to make sure that the improvements do come, but we need to use evidence and we need to use the opinions of the people who are actually going to be doing this work rather than assuming that we can do this from the outside. I think this leads to the idea that we need self-organizing teams. Now, we can have centrally set targets, provided again they're evidence-based, but the self-organizing teams need to be given discretion about how they improve the way healthcare works within the sphere which they occupy. We can monitor them against targets, we can have system-level goals, but we need to make sure that those are all aligned in a sensible kind of way, and that the actual way, the actual means by which we deliver care is from the bottom up. Presuming that somehow this is going to happen through choice or through competition simply doesn't stack up in terms of healthcare. There's no way I can see that will go. Equally, and the final killer for me on this is that if you look at all the costs of actually putting in place a marketplace, all of the costs that we put in place around contractual monitoring, about setting up frameworks in which we can put in place contracts in the first place, if we start trying to put in place mindless targets that have nothing to do with clinical evidence, we end up spending masses and masses of money on things which don't actually achieve any kind of measurable outcome. Certainly if you think about this in the context of the UK, which is the system that I know best, we've been trying to have a market in place for care since 1990. The benefits that have come from that have been relatively minor. If you were to balance that off against the cost of implementing the systems which have been put in place to measure competition, which have been put in place to put all the contracts in place, all the negotiating over contracts every year, we've spent billions and billions of pounds, possibly tens of billions of pounds on all of that stuff. Wouldn't it have been much better spent in the first place on actually trying to improve care? Okay, thank you very much for your attention. I hope that's been useful to you. Thanks.